I'm just going to be more objective. I'll make a disclaimer. I do computer-navigated surgery in each and every case for the last 8 years. So I'll be slightly biased towards technology. But I assure you that this is not going to happen. We'll still need to keep a human angle to the whole equation, and the robots are not here to take over, or the navigation is not here to take over. And I'll start with an interesting premise. So this is a study which we did and published in the Journal of Bone and Joint Surgery. What was the normal alignment in the patients, and what happens when the patient walks, when he stands on a single leg, when there is a double leg stance. And what we found was very interesting. The normal alignment was 1 or 2 degrees of varus. When the person stands, it goes into 4 degrees of varus, and on a single leg stance, it becomes 5 to 6 degrees of varus. So most of the technology, what it does is it gives us a static value, 0 degrees, when the patient is on the operating table, but it doesn't take into account what happens when the person walks. So I think the other thing which we need to take into account is the paper from the paper which suggested that the normal patients could have, the Bellamans paper which said that there could be physiological varus in a lot of the people. So whether chasing a 0 degree axis is the correct goal or not. So when we don't know what the goal is, sometimes we have to be careful embracing technology. So we have the Insall Award paper saying that coronal malalignment of more than 3 degrees can cause premature implant failure, but at the same time we have the Danbury and the Parrott paper which says that an alignment within plus or minus 3 degrees does not ensure a long-term survival. So there's a lot of conflicting evidence. We can take what we want. But eventually, the alignment optimization and gap management is only one of the aims of a total knee arthroplasty for long-term success. And 4 different strategies have been evolved. One is the CAS, the second is the robotic assisted system, the PSI, and the soft tissue balancing technology. So let us see what happens. The CAS was first used by Fred Picard in 1997, and the early designs were CT based, and they evolved to imageless systems like this, which typically have an infrared camera with the infrared trackers. And there were a lot of studies which have supported the use of CAS. Paper from Rajesh Manyar suggested that even when converting from a conventional to CAS surgery, the margin of error in alignment is reduced with the use of CAS. So this is something which you can definitely vouch for, so that if you know what you are trying to achieve, it will help you. It is a tool. You can intraoperatively quantify the amount of deformity and precisely do the soft tissue release and know what you have achieved on the table. So you can allow for a dynamic goniometry. So this is another advantage of both CAS as well as robotics. And studies have shown that the need for soft tissue release is significantly less with navigation. And this particular study suggested that in 93 patients, only 10 patients with CAS required release as compared to almost 70 to 80% people who required soft tissue releases, because you're aware of what you're doing. And there are a number of studies which have shown that the computerized navigated system was accurate to at least 1 millimeter for measuring the gaps during the surgery, and I'm sure that will be true for robotics as well, as Dr. Narendra nicely pointed out the surgical technique. Coming to the gross deformities, we have found that it is useful, but the literature doesn't agree. It says, the paper from Arun Milaji says that if you have a 20 degree or more deformity, CAS probably is not as accurate. The residual varus was more in patients with CAS. So you have to remember that it depends upon what you are registering, and if your data is garbage, then the output will also be garbage. So that is what is the limitation of CAS. I was at a meeting in Munich, the World Computer and Navigation Users Congress, and a lot of surgeons came and asked, okay, this is there, what does the computer want me to do now? The computer doesn't know what you want to do, it doesn't have a brain. So you are the boss, you have to decide what the technology does to the patient. So you need to have a plan, and that is where we must be cautious. Blood loss has been shown to be lower with CAS. We ourselves have now published that with the use of tranexamic acid, this is no longer true. And several meta-analyses have shown that although the mechanical axis alignment is better with CAS, I showed you in the beginning, we really don't know what mechanical axis we are chasing. The most important paper supporting CAS has been the Australian registry thing, and I find it a tough job to defend CAS most of the times. There was a decreased revision rate in more than 40,000 patients studied for more than 13 years, especially in the patients who are younger than 65 years of age, with the use of computer-assisted surgery. And this is one important thing which will hold good both for PSI, CAS and robotics, although there are no papers with robotics and CAS, robotics and PSI. With conventional TKR, the mean embolic score was higher and the risk of pulmonary embolism is theoretically higher as compared to a thing. Whether it will be clinically relevant, we do not know. This is the most important crux of any technology. So if you want to inculcate the technology into your practice, you must have a cost effectiveness which is calculated by the US Medicare as $50,000 and CAS just falls short of that. So if you have 50,000 quality adjusted life year, per quality adjusted life year improvement in the cost, that is when CAS is supposed to be cost effective. So it just falls short of that. And this particular paper shows that if you have a Markov model which is generated, if the volume is very high, then that is where probably CAS is cost effective. So compared with conventional TKR, it is cost saving only in the long term and offers small additional advantages. Disadvantages: learning curve, potential fracture risk, and increased surgical time, theoretically increasing the risk of PJI. There is very little evidence on the robotic techniques. There is the latest Navio technology has been approved by FDA as late as 2016. So it is something where you need to wait and watch. And there has been a lot of evolution in the robotics, and you can see that you have the imageless navigation system. But the high initial capital expenditure, almost $400,000, does it justify the use of robotics routinely? It is something which is very difficult to answer as compared to the CAS. We have this exciting soft tissue balancing technology, the ViraSense, where you can measure the thing, and this is where I think there can be some benefit to the patient, because if you use a technology like this and you can measure the balancing, that is when probably you can optimize the outcome in the patients in the long term. PSI, again, lot of meta-analysis have shown that there is no evidence to support the use of PSI. Too many devices have been used, the MRI-based, CT-based, the combined techniques, and therefore there is no clear-cut evidence to support the use of PSI. And also the studies have shown that further studies are needed to evaluate precisely the economic impact and effectiveness of the PSIs. So to summarize, at the current way the knowledge is, there is no evidence to support the use of technology for total knee arthroplasty. CAS and robotics are exciting tools, but we need to wait and watch for the long-term studies to routinely recommend it. PSI probably is on its way out, and the soft tissue balancing is what I see is probably as an interesting and useful technique for optimizing our gap balancing during surgery. Thank you very much.